Good morning. So, welcome to 10th session of our Pristine Physiology. So, today we'll be taking this second part of resting membrane potential because from tomorrow we'll be starting with action potential, right? So, let's start straight away. So, we learned this thing yesterday that it is the nernst equation, correct? It is the nernst equation which is for individual ions. And for individual ions, it was calculating that what would be the electromotive force which will actually be controlling that whether the ions would be moving out or in, and at what point there would be a stability. Correct? So this is what we learned yesterday. In nutshell, it was like minus 61 upon the Z, and then there was log of 10 concentration inside that bindi up and concentration out. Right? One very funny email which was received is that every time, why do you say that bindi up? I usually say it again and again because when it is like when you really write this nernst equation, so this thing will strike in your mind. It will be cemented into your brain that yes, this is the point where we have to remember it, right? One very interesting thing is the thing what is called as the NLP, neuro linguistic programming. It is called as neuro linguistic programming, right? Programming. This is pretty interesting, right? I used to take lectures on this, but what neuro-linguistic programming is, let's say if someone is not comfortable whenever there is viva, right? And this is a fact. Many of the students, if you really see their theory marks, they are brilliant, but when it comes to viva, right, they are destroyed. Why? What really happens? It's in theory they were supposed to write, but because there was no one watching them in viva, when they feel like sir is watching me, or if there are other students who are watching me, and they become nervous. Plus, there are no chances of any gappabaji, right? You just can't bluff. Over here in theory, to active, passive, right? Then point number 1, point number 2, point number 3. Next page, start with point number 5, 6, right? All these tricks, right? Even teachers, they know that all these tricks they have been they are getting played, right? Active, passive, same point described in other way. But in Viva, those things are not possible. But even sometimes you know the subject. Still, if you find that it is difficult, so then you need to really know about what is called as the NLP or the neuro-linguistic programming, where we actually talk with our brain, and gradually you'll find that our brain responds as we ask for. And for that, we need to do what is called as the tag, right? Say for example, some tags. I give you one very small example because today's topic is not only a bit short, but we'll be adding the clinical part of it. Okay, so if it really happens to you, right, you must have noted that, say this I'm describing one small event. Say for example, someone has invested 1 lakh rupees in equity, right, or the share market. Why I'm telling share market? Because this is something which immediately hits the heart, right? Normally, it is said that you should be not only lion-hearted if you really want to invest, and at the same time, you should be absolutely cool so that you know what you have invested and you know that with the market ups and downs, that's fine. Whatever you have done is going to fetch you good money, right? And you have to watch for the entire portfolio and not for अरे मेरे 12 stock में से 2 stock नीचे चलेगा अब मैं क्या करूँ. No, those 10 they are soaring high, they'll cover up, right? So what I was telling is that it is the money which hits tremendously, and seriously, no jokes, the psychiatric cases right? Psychiatric cases, they increased, yeah, they increased 12 times when in COVID market crashed. And most of the cases, all those males, they were telling that their entire sexual desire, it vanished. It happens because they are so hyper, right? Arey paisa chala gaya. They don't understand that the moments which are getting lost, they are more important. But the point is, when this is such patients are to be treated, I'll call them patients, right? When such patients are to be treated, NLP is one of the mechanisms. What it really tells is that gradually you control yourself, right? There is a method, and then it's like that when you start feeling nervous, right? All you have to do is, this is one of the example, that take two fingers and then tap. So no one would know that what is your tag. It could be anything. It could be really anything. Someone might make a fist, right? Someone will do this, anything. It is completely a personalized thing. But the moment that thing is done, it will start sending signals to the brain that, okay, you are into a different zone. Right? These are some very powerful methods. So indirectly, what I am every time doing is, because this nernst equation is very important, and this is the point where chances are very high that someone can make a mistake. But when it is said 5 times, this is concentration I and this bindi is always on the top, done, no worries. Now no mistake. But rest of the areas, though they are fine. You will not make mistake over there. But once this portion has been saved, the dot concentration of I is up, you are through. Because see, in medical, as you will progress, there will be so many things. So then why to use your brain to remember these conditions, right? Pavlov's conditioning जैसा. Yes, yes, I would agree to that. Pavlov's pouch, right? That kutta wala, right? That is pretty near to it, but this is even more advanced, right? We'll talk about it one day, and you will be surprised, because there are few exercises which are to be done. So for example, one of the exercises where you have to improve your sensitivity. So you have to put 1 रुपया 2 रुपया 5 रुपया 10 रुपया, all those coins into the refrigerator, make them chilled, right? Say for example, 4-5 coin 1 रुपए के, 2-3 2 रुपए के, random, and then similarly few random coins outside, right, which are at a room temperature, and then you have to mix all the coins, and you have to close your eyes, and then you have to figure out, pick a coin and find out कि आंख बंद करके ये कौन सा coin है, 1 रुपए का, 2 रुपए का. But because it's not only the temperature, but it is your entire kinesthetic sensations. So every sensation, your fingertips, they become so sensitive. So gradually there are various exercises which will start activating various parts of your brain. And trust me, it is a matter of about 6 months. After 6 months, it's not so that you'll be good in one field, you'll be good in multiple fields, right? These are some very powerful systems, but actually when sometimes you talk about it, people make fun out of it. क्या रे, ऐसा तो होता है. But yes, I always say, whatever I'll be telling you, first I experiment on myself. If it is doing good, then and then I tell to anyone. Otherwise I don't tell, whether it is finance or it is medical or it is engineering or anything. Okay, so that was the answer, that why many times I keep on telling some things again and again, so that you never make mistake in your life, because I did those mistakes. मैंने की थी, right? And seriously, concentration outside above, concentration inside below, and the number which came was crazy. Means it was some in thousands. मैंने कहा इतने वोल्ट तो हो ही नहीं सकते. But I wasted some precious time in that. So why should you pass through those troubles? Okay. So this was the reason. Okay, so this was our nernst equation, which was about the individual ion. Achha, you asked, sorry, yesterday, after that I realized that you asked some question about where is that table. So I don't know, I somehow missed that question. It was just asked at the end. So here is that table. Here is the table. Right? This is Guyton, and here is the table where all the, right, say this is the neurons, the minus 60 to minus 70, skeletal muscles, smooth muscles, cardiac muscles, right? These are very important. Then hair, cochlea, right? Minus 15 to 40, astrocytes, erythrocytes, and yes, this is the photoreceptor, right? In dark, it is minus 40, in light, it is minus 70, right? So this is the table what I was talking about. Okay. No need to cram, but because we'll be coming across these again and again. At this point of time, just do remember this neurons, minus 60 to minus 70. This is 14th edition, right? This is 14th edition. Okay. So let's go back to our, yeah. Hmm? Yeah. So but in reality, things are never like this, right? Individual ions, they don't work like this. It is always a combination. And for combination, this is the Goldman question. Which edition question mark is for? That was Guyton. That was Guyton. Guyton's 14th edition. So Goldman equation. So this Goldman equation is for multiple ions. So again, it would be measuring things in in millivolt, and this is the electromotive force which would be measured into millivolt. More or less, it will go quite similar. Minus 61, right, into log of concentration inside that bindi up, but concentration of what? Sodium, into permeability of sodium plus same way concentration of, I think log, I should write it over here. Log, I should write over here. Yeah, now this is fine. This is fine. So similarly, this is concentration of outside sodium, permeability of sodium. But rest of the structure will go like this only. Concentration inside, that's potassium, and permeability of potassium. Over here, this is concentration outside, potassium, permeability, potassium, plus take the chloride. So concentration inside of chloride, permeability of chloride, plus concentration outside chloride, potassium, permeability, chloride, right? That's the Goldman equation. Now what this equation really tells is, it tells few very interesting points. Few we have already talked about. So when Guyton tells that, it is very evident from this equation, right? So what it really tells is, one, that it is the sodium, potassium, and chloride. These are most important. These are most important for, well, for membrane potential, right? For membrane potential. We are not talking about only the action potential or the resting potential. We are talking about they are most important for membrane potential, right? These are the ions, most important ions which are meant for membrane potential. Second interesting thing, and this is, I'll put a star, that if any membrane, right, if the membrane has zero permeability, right, zero permeability for any two ions, so then what would happen? Well, it is but obvious. Whosoever is left out will dominate, right? Third one would dominate. Right? As such, if you see, there is no big rocket science in that. That if rest of the two, because when the permeability becomes zero, let's say permeability becomes zero, so then this value becomes zero. If this value becomes zero, this entire thing, this is zero, this is zero, right? If this is also zero, because if the permeability is zero over here, then this also zero, only the potassium will be dominating. Correct? That's how it goes. Okay? If the permeability of any ion is zero, done. Permeability zero means it won't allow that ion to pass through the cell membrane at that point of time. At that point of time, right? Later on, whatever is happening, but at that point, it is not allowing. When everything is stabilized, when everything is completely at an equilibrium, at that point, that sodium is not doing anything, right? It is not allowed to pass through. So that means in Goldman's equation, its value will become zero. Perfect. Okay. So what he said is that is at permeability of two ion means balance. No. Permeability means the ability to pass the membrane. Say for example, say this is our cell. Let's take a new page, right? This is our cell, right? And in this cell, say that's our potassium channel, and this is our sodium channel, right? But this sodium channel is blocked. So when the sodium channel is blocked, that means sodium is not allowed to go outside. It means its permeability is ability to pass through the cell membrane, it is zero. So it means this sodium won't be taking any part at this point of time when everything is getting balanced properly. So it is the potassium who is playing a major role. Am I right? Am I clear? Right? This is very vital, because we'll be watching clinical conditions today, right? And in such a way that I'll tell you, okay, these are the two patients, and look at both of them. Absolutely same clinical symptoms. There is no difference, right? So, but once you understand this, you'll be able to say, okay, obviously this will lead to muscle flaccidity. Flaccid means muscle becomes soft, right? Muscle becomes soft. So there you will understand that why this patient is having kare mera dil dhadak raha hai, palpitation. When you start feeling your own heart beating, it is called as the palpitation. It is a feel, right? It is a feel. When it goes wrong, it goes wrong into the form of cardiac arrhythmias. If it still goes wrong, it goes into the ventricular fibrillation. And when it goes to fibrillation, so then it is game over, right? It is very bad. More or less like permission to go out or in. Absolutely, it is exactly like permission to go out or in, right? More or less, nahi. It is exactly, right? Perfect. So this is true. So these were the 2 points. Then the third point, though, superbly well, because yesterday we talked about it, right? And then it came into this Goldman. But when we say that this is a cell and outside there is less positive, inside there are more positive, so then the flow of ions will be from inside out, right? Obviously, right? This is inside out. So the final result would be the cell would be more or less electronegative, right? It would be more electronegative, correct? Because we are losing cations, we are losing positive ions are going out, so relatively our cell will become negative. That was the whole principle, right? This is what was happening in case of potassium, and vice versa. Right? And vice versa. If we talk about sodium, so then sodium, when it starts entering into the cell, because sodium is more outside, sodium is less inside, more cations are entering into the cell. So obviously cell will become more electropositive. Means wherever it is, from there it becomes more positive. So it is like from -80, it reaches to even -70. But yes, definitely this is becoming more positive, right? This is becoming more positive. This is 0. -80 is here. -70 if it is here. So yes, we are moving towards positive side. So it is positive, right? So this is the third interpretation. And the fourth interpretation is, this is really very important, that when we talk about permeability, right, when we talk about permeability, permeability of sodium, permeability of potassium, and permeability of chlorine, out of these two, this negative ion, right, it, though it is mentioned into Goldman's equation, its importance is very less, right? So you can say it is not permeable, right? Then why have we included it into this situation? Because there are few specific, why we have included it in Goldman's equation, because there are some conditions when it will come into picture. But when we are studying normal physiology, it won't come into picture that fast, right? Our entire game would be dependent on sodium, potassium, and yes, when we'll be talking about the cardiacs, to then even the calcium will be coming into picture, right? With a major role. So basically, it is the sodium and potassium, right? They will be playing the major role. This is good, huh? Depolarization, Jaggu Dada, and repolarization is Rotlu. Yeah. So depolarization, right? When it is this from minus to plus. Very good. Right? And then from plus to minus, right? It is this. Right? So this is repolarization. Good one. Good one. Right? Rotlu. So sodium and potassium, right? They change rapidly. Their permeability, they change rapidly. And because it is changing rapidly, it is going to make a marked difference into our entire potential, right? So these were the major things. Now, let's talk about, say, this one. This one is blood. Okay. So in other words, I'm talking about plasma. So this one is plasma. This one, these are the cells, right? So this is intracellular fluid. The fluid which is surrounding it is interstitial fluid, correct? Interstitial fluid. And this interstitial fluid is in communication with the vessels or the capillaries, and this is the plasma, right? Combination of these two, plasma plus interstitial fluid, is ECF, the fluid which is outside the cell. I'm writing this thing so much, I'm not doubting your intelligence, but because in one mail, the question which you have asked, man, why are you mixing interstitial fluid into intracellular fluid? Right? Remember it, interstitial fluid is not in cells. It is surrounding the cells. Right? Eh, so be very clear in that. And this intracellular fluid, that is literally inside the cells. Yes, intracellular fluid is making a big role, right? It is 40%, right? Yes, it is big, but that's the reason that there are so many cells. And they have all these cells, they are loaded with one ion, and that is potassium, right? They are loaded with potassium. Because the inside, if you see, it is 140, and outside it is just 3.5 to 5.5 milli equivalent per liter, right? This is what you get in extracellular fluid, and this is what you get in intracellular fluid. That means there is tons of potassium inside the cells. So in case if anything goes wrong to these cells, right, they will release the potassium like anything, right? Because any injury to them, they will release, and that thing can lead to multiple complications. Okay? Acha. Chalo. I give you one situation, and then we actually see that what really happens, and we'll see purely on the basis of graph, right? So we draw something. this. Now you know what it is, right? This is like timeline, and this is like millivolt, right? Millivolt. Let's draw one first line. Now we can say that, let's say over here we draw, right? So this is, if it is resting membrane potential, right? Let's say we are talking about now, so this is minus 70 millivolt, okay? Minus 70 millivolt. At this, it is the resting membrane potential. So as things start moving, right? As things start moving, right? As that there is leakage of potassium, it goes outside, the cell starts becoming more positive, and it starts rising gradually, because these are slow process, right? At one point of time, still we are not discussing, right, the action potential, right? No, we are just understanding some concepts, that where would those sodiums, they will come into picture, because till this point sodiums, they are not here, right? They have not entered into picture, those channels are closed. So let's say at minus 60, just an example, minus 60, at minus 60, this is the situation in the cell. Those sodium pumps, they are, now we are clarifying, they are voltage operated, right? Or the voltage gated sodium pumps. So it means those pumps, they will open only when the voltage is minus 60 millivolt, right? So at minus 60, those pumps will open. As these pumps will open, what would happen? These are fast pumps. Tuck, 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 right? Sodium will start gushing in. And it will lead to, right? It will go positive. This is going positive, so we call it depolarization, right? So this is depolarization. Things are going from minus to plus. But who is responsible? Well, potassium was responsible till it reaches to this level, and then the sodium kicks in, and who takes it to higher level? Rapid influx. Exactly. Very good. Fantastic. Right? It is what is called as the influx. Rapid influx of sodium. Right? So it goes in. So this one, this minus 60, we give a name, and that is called as the threshold potential. Threshold potential. This means this is, as we say, this is like a switch. Till the water touches that level, this switch will not operate. The moment water touches that sensor, tuck, the pump stops, right? So, but this is exactly like it. This is threshold potential. At this point, even if there is 1 volt less, 1 millivolt less, it won't work. The moment it hits that, and it starts working. So this is what really happens in this case, right? This is normal, right? This is normal. Now we'll just keep this figure in mind. We'll come back to this, relay switch. We'll come back to this image just after 2 minutes as I explain your situation, and then you have to tell me what would happen. What would really happen to this graph? Okay? So let's take it to other. Now here is a patient, right? This is a patient. This patient, for some reason, right? We don't know the reason, but for some reason, this patient is having decreased intake, right? Is in decreased intake of potassium, right? He's not eating bananas. He's not eating pineapple, right? Or, right? So this is the chalo, it is less, but he is taking laxatives. He has got constipation, right? He is taking laxatives, and laxatives so much that he is almost abusing it, right? Abuse of laxative. abuse of laxative or abuse of any of the medicine, the medicine is innocent, but you are taking it in such a large dose that it becomes like an addiction, right? So this is like abuse of laxative. Then let's say this patient is having vomiting, severe vomiting, right? Or this patient is taking diuretics. Diuretics. Okay. Let's. I'm writing here again on next page, right? Diuretics. 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 Ticks. Diuretics are those which will induce the passage of urine, right? So more urine would be passed. There are two major groups which you must know, right? Must know. One, which is potassium wasting diuretics, and second one which is called as the potassium sparing diuretics. In physiology we'll be going into depth about it. What are laxatives? Laxatives are those who are taking it for constipation, right? Which allows the passage of stool, right? It is used for, right? It is used for constipation. Say for example, people take like isabgol, etc., right? But when someone is taking Dulcolax, right? So Dulcolax is one of the laxative. It allows the passage of say stool, right? Easily. Okay. So here it is coming back to this potassium wasting and the potassium sparing. Potassium wasting, they allow the potassium to pass into the urine, right? So one, what is called as the thiazide. Now these thiazide, it is like a group, right? So chlorothiazide, hydrochlorothiazide, these are all groups, right? Chlorothiazide or hydrochlorothiazide, hydrochloro, right? I'm just writing T. So hydrochlorothiazide, chlorothiazide, and then others are called as the loop diuretics. They will be acting on loop. Name itself is telling they'll be acting on loop of Henle, right? Where there is counter current mechanism. Things which are released, again it is picked up, again it's picked up. So concentration rises. So that's how the good things they are taken away, and only the urine where it carries all those waste products, it goes out. But these loop diuretics will prevent it, right? So one of the commonest medicine which is called as the furosemide, also sold in the form of tablet Lasix, right? This is a very good, very powerful, effective, but do remember that it can lead to potassium wasting. Potassium sparing, these are the medicines which will not waste potassium. It will take the potassium back, but more urine will definitely pass on, right? So spironolactone, right? Very famous spironolactone. This is one of the very famous this potassium sparing diuretics. Then amiloride, commonly given, right? Amiloride, very common. So remember this, that when person is on these, so he'll be losing potassium, right? So that's why over here in diuretics we say potassium wasting diuretics. Potassium wasting. Potassium sparing is good. Yeah, at times potassium sparing is good, but well, depends upon what the situation. That's why we are taking this clinical part, right? You'll understand within minutes that why both these two types of they are needed, right? Because there are so many other things which will be playing role. The biggest role is by kidneys. Those kidneys, they are the big boss, right? They are the big boss in handling potassium. They are the biggest one. So they react whether the potassium should really pass on or it should be restricted. So they are the big boss in potassium regulation. Potassium regulation. Very nice, right? You will get the answer of this, that why we do this, right? Yes, tea and coffee are also diuretics, but they are not as strong as compared to when you talk about furosemide or spironolactone, right? Not as strong, but yeah, definitely they are diuretics. Achha. Now tell me, if this is the situation, right? If this is the situation that patient is losing potassium, right? Patient is losing potassium. So this is called as the hypokalemia, right? We used to speak like that, right? Stylish way to speak is hypokalemia, right? But we always used to speak like hypokalemia, right? तो वो याद रहता था. Hypo means less, kale means potassium, and mia is, in fact, not mia, it is emia, right? This e को यहाँ ले आइए. So this is blood. So that means there is less potassium in the blood. That is called as the hypokalemia or hypokalemia. So when there is hypokalemia, this is where there is less potassium into the blood, and when there is in the blood there is less potassium, that means we are talking about ECF. Is that fine? Right? No confusion in this. Hypokalemia means there is less potassium into the extracellular fluid. Now see, we go back to this image, this one. So here is, let's make a big cell, right? Big cell. This cell is loaded with potassium, correct? And now we have got this drops. Over here we have got less potassium, right? Potassium level drops because that's what we said, hypokalemia, correct? So what would happen in this case? Yes, it will go outside the cell, agreed. But what can really happen when there is hypokalemia? What can really happen? What can really happen to that, to this resting membrane potential? Because now there is less potassium outside, right, as compared to normal, and there is more potassium, right, or even the normal potassium inside. Resting membrane potential was that point when there is a balance, correct? So it means what would happen inside the cell, because now outside is having less potassium. So what would happen? Will this cell become more electronegative, or it will become more electropositive from that point as compared to normal? In normal, let's say there are three potassiums outside. Inside there are 50. Repolarization? No, don't worry. Yeah, it will be positive. Yeah, exactly. It will become more negative. Because, see, now there are less potassium outside. So more potassiums, they will be rushing outside to balance it. Correct? More will go out. So this cell will become more negative. When it will become more negative, this is what really happens. Its resting membrane potential would drop, right? So this would be a new, let's say it is minus 80 millivolt. It drops, right? So this is because of hypokalemia, right? Because the cell has become more negative, and then it would stabilize, right? So this is minus 80. So will it affect this threshold potential? तो it is अपना fix, because at minus 60 तो बस तलवार लेके sodiums will come and चलो fire. But what would happen? Now from this point onwards, it has to once again rise, and it has to reach to threshold, and then the firing would start. So it will take more efforts. Yep, right. This thing will take more efforts, है ना? Because previously you were supposed to rise from -70 to -60. So now it has to rise from -80 to -60. Right? So it will take more time. Exactly. So and more efforts, right? So it is going to take more time. Till that time, what would happen to that muscle or what would happen to that nerve? Will they be working? Till that point. Till that point, right? During, I'm talking about this point, right? Will the muscles be working? Yeah, more ATP will be used. Huh, exactly, Chirag. Exactly. Muscles, that nerve, they'll say, let the sodium boss come, fire, right? And then the action would start. Till that point, the things are like rest. They won't work. But this is the thing. This is the thing. That is what would really happen in this case. The patient, what patient would suffer, right? The clinical symptoms. Okay, let's write clinical symptoms here. The clinical symptoms would be one, there would be muscle weakness, right? Muscle weakness. And this muscle weakness is in the form of flaccidity, flaccid muscles, right? There is no tone. Rest or statue in that position, yeah, right? And it is flaccid, right? It is flaccid, soft, right? What would happen in case of, because this is about the skeletal muscle. What about the digestive system muscles? Now they are also flaccid, right? If they are flaccid, it will lead to nausea, vomiting, right? Because they are losing their tone. So unnecessary, there would be nausea, vomiting, right? What about the heart? Because of this, the heart will start getting a feel of, and you person would feel palpitation, right? There would be palpitation, feeling of as if the heart is beating, right? These are what are the symptoms of hypokalemia, right? Hypokalemia. Now, when we talk about hypokalemia, one thing is crystal clear, that it is the kidney which is involved, right? It is the kidney which is involved. So, because kidney is the major contributor, so kidney is the major contributor of controlling this potassium. So even in that case also, it can really occur when the kidney is working more, right? It is, and especially say in the form of diuretics, where it is leading to potassium wasting, right? That's where the maximum potassium wastage is occurring. Well, it is like, because muscles are not working, so that's why that food, that propulsive action is not going properly. So that's why it is because of reflex action, right? And cardiac, yes, when things go wrong, right, then it can lead to arrhythmia, right? Arrhythmia means all those irregular patterns of cardiac. So we understood that in hypokalemia it occurs like this. Let's take the reverse situation. And this reverse is, obviously, that would be hyperkalemia, right? So then which there is increased potassium, right? Increased potassium. Now, normal potassium level is 3.5 to 5.5 milli equal per liter. This is the normal level. You need to know this. You need to remember this, because whenever you'll be watching the lab report, this is the first thing which you have to watch, right? And then I'll tell you something from the clinical perspective, that whenever there is any trouble in the kidney, right, we go for urea, urine, urea, creatinine, right? We go for all these serum creatinine, serum urea, and we find that it is high because kidney is throwing these things out. But don't miss the potassium because kidney is the big boss. Kidney is someone who will be releasing that potassium. Now it is not allowing to go because kidney has gone into failure, acute renal failure or chronic renal failure, right? This is renal failure. When the kidney is failing, so that means that potassium is not going. So it is mounting into the serum, right? No, when the kidney is failing, it is not allowing the potassium to go out. It is remaining into the serum. It is remaining into the blood. It is remaining into extracellular fluid, right? So this is what really happens in this case. So when it rises more than 5.5, so then it is called as a hyperkalemia, right? It is called as hyperkalemia. You came across such patient, right? When this, we'll see the cellular level that what really happens, but because we are discussing clinical, so let's finish this thing first. You come across this patient that are a report serum potassium higher than 5.5. At times you'll find that yes, patient is there, right? Patient is having high serum level, but somehow you feel that there are no symptoms, right? There are no symptoms. Patient is normal, right? No symptoms. You take a history and you find that no, there are no apparent cause. There are no apparent cause. So no need to panic. No need to panic. This could be pseudo hyperkalemia, right? Pseudo means false, right? Pseudo means false. It is hyperkalemia, pseudo hyperkalemia. So it means your history taking is very important because then and then you can rule out the causes, right? Because the next step is immediately go for ECG. You go for ECG, and when we'll be learning ECG, I'll show you at every spot what happens when it goes above 5.5, what happens when it goes above 6, what happens it goes above 6.5, so that when you have got the ECG and the lab report, you can actually visualize that, boss, this is what is going on in the heart. And when it goes beyond 8 or 8.5, confirm this patient is going to die in ventricular fibrillation. It is that dangerous, right? So that's why your ECG and your lab reports, they matter the most. Even your common CBC, right? We'll be discussing even that also when we'll be discussing the hemopoietic system, when we'll be discussing blood. That every point, right? That why everything is so important. So in hyperkalemia, nerve supply is good. So it is good or bad? Wait. You have to answer this question, right? You have to answer this question. But first we talk about that what history will you be taking? That's why I'm taking this clinical part. Yes, I know, right? Even one of the mail has come that for the first year students, why so much of clinics? I'm not forcing you that yes, you remember everything, but because when you remember this, automatically you'll start remembering the physiology so crisply, right? How EC is related to kidneys? Wait. Just wait, right? 2 minutes. You yourself will give the answer. Acha. Chalo. So history is important. You know that history. What questions you should really ask? Questions you will be asking on the basis of how this can really develop, how the hyperkalemia can really develop. The commonest things, commonest, right? One hint that it is the cell in which there is so much of potassium, right? So if this cell breaks, immediately all this potassium will be released into the ECF, extracellular fluid. It is ECF that is into the interstitial. From there it will come into the serum, and in serum you will measure, and it is the serum potassium what we are measuring, right? Immediately we can measure. So it can come out when large number of cells are broken. The commonest reason, accident, right? Now see, in accident, that is technically which is called as the trauma. Trauma, right? Trauma is accident. In trauma, say one type of injury in which, right? Say there is, this is very crude way to explain, but yes, we need to know. Those machines sometimes they say, "अरे हाथ कट गया," right? हाथ कट गया. So with that, that thing is sliced, hand is cut. But if you really look at the tissues, right, the tissue injury is less, right? This tissue injury is less as compared to if someone's hand goes into the machine and then the whole tissue is literally squeezed, or बेचारा कोई रोड पे पड़ा है and the wheel of the car goes above him, right? They are called as the crush injury. They are called as the crush injury. So in emergency, when you see that there is crush injury, first thing which should strike to you, looking at the patient's condition, that just check serum potassium. Everything fine, right? But patient can die simply because of hyperkalemia. Everything can be managed, but because this thing is ignored, it can cause a havoc, right? We'll see that how it can happen. So this is one, crush injury. The second, in one shot, so many cells are destroyed, burns, right? When we'll be discussing burns, that what is type 1, type 2, type 3, right? What happens to tissues, which layers. But when in general, massive burn leads to massive destruction of cells, and all the cells, they release their potassium into the extracellular fluid. Now these are the major. Third one, right? Third one. These are all the factors which one should ask. The third one is severe infection. The infection where there is, which is called as the septicemia. Septicemia. Septicemia, very high grade of infection. When there is development of lots of pus, lots of cells are destroyed, severe, that it can really go into septicemic shock, right? Major surgery. Major surgery. Why major surgery? Well, this is like, that's why it is said that if you are artistic, right? If you are artistic, more sensitivity, more irritating. Yeah. So major surgery. Surgery is like an art. When they say, okay, it is like a bloodless surgery, right? Many surgeons, they have got the habit to put bigger cuts, right? But the surgery is very neat. Sometimes, right, when the surgery is done, and if it is like destruction of the tissues, when lots of manipulation, lots of tissues, they are getting destructed, it can lead to hyperkalemia. And obviously we said that it is the kidneys, right? They are the big boss, right? Septicemia means infection, severe infection, right? Severe infection. That infection which is to be treated by intravenous medicines, intravenous antibiotics, there is no other option, right? It is like a major emergency, right? So say all these, they come under the shock. When the body is under the shock, or body is under that condition, which can be fatal, right? Which can set to that vicious cycle. So septicemic shock, vasovagal shock, these are all various types of shocks, right? Right. So that is also one of the major topic. But see, what I'm trying to explain is, see how beautifully everything is interconnected. Correct. So major surgery. Then now we come for this kidney, right? The renal failure. Renal failure. So kidneys, they are throwing away. Kidneys, they are throwing away the excess potassium. Say if someone tells ke chalo, today I eat 10 pineapples, right? You can eat. Pineapple is loaded with potassium, so you won't be developing hyperkalemia. No, nothing would happen to your heart, nothing, because the speed at which you eat, The kidneys are super boss. They will be throwing away at the higher speed. Nothing would happen. Because when it will be absorbed through the GIT, then it will come into circulation. Immediately kidneys will catch them and ke chalo bahar, right? Out. Nothing would happen. You eat lots of bananas, right? Nothing would happen. Otherwise, so all the monkeys would be suffering from hyperkalemia. They never suffer, right? Their kidneys are also that good. So, but when there is renal failure, whether it is acute or it is chronic, right? Again, major topics in nephrology: acute renal failure and chronic renal failure. I'm just writing something because I need to talk about it. Clinical, bus, right? We'll talk about it. Huh. So renal failure, acute and chronic, right? They all can lead to hyperkalemia. So when the hyperkalemia is there, right? These are the very important. Then there is acidosis, various type of acidosis: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. These four super confusing topics, right? We'll take it. Right now, deliberately, I'm not adding acidosis and alkalosis in this situation, but yes, it can come, but I'm not adding it because it will add unnecessary the confusion, right? Ha, ha. Yes. Now, right, so these are the conditions, these are the things which you will ask. And in renal failure, yes, it is the serum potassium that should always be asked first. Okay, if this is the situation, now we go back to that image, and then which this was our, say, resting membrane potential. It was, say, minus 80, and this is our RMP, resting membrane potential. ठीक? What would happen in this case? What would happen? So here I am drawing it, right? This is a cell, right? This is a cell, and now there is so much of potassium inside, outside, right? This is ECF because we are experiencing hyperkalemia. What would really happen? Because here also, right, there is lots and lots of potassium. So what would happen now to the cell condition? Will it be more electronegative or will it be more electropositive? What would really happen? What would really happen? In meantime, in this you can add one more thing, that if the patient is on, yeah, electropositive, right? Sally, not negative, right? See, bahar there is so much of potassium, right? So only few will go and bus, kaam band. So your resting membrane potential, RMP, right? RMP previously, which was minus 80, now to there are so many outside, so it would be raised. It would be raised, and let's say, just for the example, at minus 70 it would be satisfied. Correct? At minus 70 it would be satisfied कि बस इतने पे काम खत्म. So as such you are right, it will become, from that position it will become electronegative. But for the resting membrane potential point of view, less potassiums they have to go outside, so they will retain their positivity, and thus RMP would rise. So this is the normal RMP, right? Now the new RMP, let's say it is at minus 70, right? Over here, just for the explanation, this is minus 90, and this was because of hypokalemia, right? And this one is now because of hyperkalemia, right? Makes sense? So, and let's say our threshold is, right? Our threshold is, let's say, minus 65, right? From here the firing would start. ठीक? So previously we said that situation was this, that it was going here and then fire. In case of hypokalemia, bichara travel, and it goes up, right? So then this was leading to more time, and that's why muscles, they were becoming flaccid. Muscles were becoming flaccid, paralysis, weakness, right? Muscle weakness and all complications. Now we are here. Now we are here. This is our hyperkalemia. What would really happen to the action? What would really happen to this threshold? What would really happen to muscles? Because that's where the sodium is going to kick in, right? Sodium channels, they are going to kick in. So our first thought is from here it starts, right? And immediately it will hit hyperactive, right? We say that it is hyperactive. Less time and less ATP. Okay, very true. That's what we really think, that's the logic, right? And it is perfectly fine. Now we go to one of the very interesting phenomena of sodium, right? Say, in case of hypokalemia, when things go towards more negative, so it is called as depolarization or repolarization. When things go towards more negative from RMP, right, this is going more negative, so it is called as, right, crying, rotlu. So that is repolarization. But repolarization, depolarization, they all are considered from this point, right? I'm explaining you two new terms. Everything is with perspective of this normal level of RMP. But if anything is going even below that, right, और ज्यादा रोना शुरू किया, तो then it is called as the hyper, right? Then it is called as hyper. That's what we say कि यार hyper मत हो, इतना मत रो, right? So this is what is called as the hyperpolarization. So remember these words. All these words from tomorrow we'll be using it like your names, right? We'll keep on telling you, okay, from this it leads to repolarization and then it goes for hyperpolarization. So immediately you know, okay, repolarization. From top it is dropping down to RMP. From RMP it is going still down. Now we'll call it hyperpolarization. From hyperpolarization it will again come to the RMP level, right? So that's how we'll be utilizing the term. Is this part clear? That why we call it hyperpolarization. So when the question is asked like that in hypokalemia there is hyperpolarization, right or wrong, right? So we say yes, it is right, right? Because hypokalemia, things, they drop, RMP is dropping. You can say Mahar, yeah, that is fine, right? Hyper rotlu. So this is what really happens. Now, if this is the situation, so then when RMP itself is raised, right? So in ECG, repolarization will be, yeah. In ECG also all these things will come. ECG is what? ECG is just the representation. It is the written representation of all these actions. Only thing, cardiac, right? But yes, all these things would happen. Okay. One more. When, so hyperpolarization, what should this be called? When the RMP is raised towards positivity, right? This is what is called as the hypopolarization, right? जितना रोना था उतना भी नहीं रो रहे. So hypopolarization. Got it? Achha. So this is done. Now we go back to our original point, this. So one thing is clear, it is into hypopolarized state, hypopolarized, right? When the RMP has been raised from -80 to -70. Now see, this is, yes, it tells that now because we are at -70 and -65 is to be triggered, that's the time when the sodium should really kick in, right? Sodium channels and then the fire. Now, there is a speciality of this sodium, right? And the sodium is, sodium tells that potassium, you do whatever you want, give me time, right? I can't work in hurry, right? I need my own time. So here is like, say this, these are the sodium channels, and they do have those gates, right? One gate closes, second gate opens, right? They move like this, literally, right? And the movement of these gate is with respect to normal RMP. So it is necessary for the sodium to give them the time, that is from 80, from -80, they reach to, when you are reaching to -65, exactly at that point the gates are completely open, right? The voltage which is getting developed, and those gates open, they need that time, and then the transfer starts. If you reach too early, right? If you reach too early, तो धम जैसे वो दरवाजा भी खुला नहीं, and you hit the doors, right? So this is what really happens when from -70 to -65 you have reached so early that still the doors are not yet fully opened, right? So they try to open, and then one door, the opposite door, it starts closing. So there is only a short time in which those sodiums, they will pass. Yeah, means at hyperpolarization it will reach its threshold even at lesser millivolts from normal. That's right, that's right. Yeah, yeah. Potassium channel won't go bad, right? Potassium channel, so they will keep on working because potassium channel has got nothing to do with what is happening, right? They just follow the course of millivolts, right? They just work on that. Acha, see, interesting. So here, sodium, the number of sodium which should actually gush inside, they won't work, right? So the real situation would be that under normal cases, right, when that sodium channel used to open, those sodium, big quantity, they were jumping in, right? Big quantity, because they were getting those five-star doors very properly opened, and done, right? Large amount of sodiums they would enter, right? Potassiums, they are already outside, and then the cycle keeps on running. But now that's not the case, right? Because of this, right, less sodiums they were able to enter, and the proper potential is not developed. So even in this case, so when it is like this, even if the RMP level has been raised, but now we are not giving the time, so that spike, which should be like wonderful spike, it never goes like this. It becomes a weak spike and then it dies, right? This is what really happens in case of hyperkalemia. So the point is that when say these sodiums, right, they are unable, right, when they are unable to enter over here, sorry, when they are unable to enter, right, so that trigger over here, it is a weak trigger, right? It is a weak trigger. Due to that weak trigger, the symptoms, all those symptoms, they will come back, right? Which symptoms? That is, in case of hyperkalemia, when we have got the level more than 5.5 milliequal per liter, the first thing first, it could be asymptomatic, right? Sometimes there is no symptom. So this is important, right? It could be asymptomatic. for some time. If it continues, definitely there will be appearance of symptom. There would be, when we talk about muscle weakness, because muscles are not triggering, so there would be weakness, right? Nerves, they are not conducting, so there would be paresthesia, right? Paresthesia, paralysis, right? They won't be conducting properly. Then, because the muscles, they are weak, still goes down, they will become flaccid. Flaccid means it loses even normal tone. Right now, if you touch your biceps, you touch your shoulder, right, you'll find that when you press, so there is some power, right? There is some tone. It is the basic tone. Even when that is lost, so then it would be like a bilkul soft muscle, right? Sometimes those who are very aged, if you touch their muscles, they will be like rui. That is flaccid paralysis. That is like a flaccid paralysis. When the muscles, they are losing their tone. The biggest advantage of exercise is that tone is maintained. When the tone is maintained, even if you are walking, right, even if it's your normal walk, still it would be much more graceful because all the muscles, they are in proper tone, right? So this is what is called as the flaccid paralysis. Another thing which is very common, oliguria, right? Oliguria means less urine, right? Less urine. This would be another hint that kidneys, they are not functioning. And when can you say less urine? When it is less than about say 400 ml per day. So when you enter the patient, you just watch that, because such patients, they will be having catheter, Foley's catheter dala hua hai, right? There is a urine bag, and you watch that urine bag. Immediately you take the clinical notes, you see that how much is the output, right? Or ask the sister how much is the output. They have mentioned that okay, it was 200 ml last evening, and today morning it was 150 ml. Okay, so in the entire day, 150, 350 ml oliguria, right? This is how the patient, and yes, definitely there would be like palpitations, right? Why such things are happening? Well, this is muscle weakness due to skeletal muscles. Flaccid paralysis, skeletal muscles, and the nerves, right? Because now nerves, they are not working. Nerves are not conducting. This is paresthesia because of nerves. This is because of kidney. This is because of cardiac muscles, right? Cardiac muscles, they are not working properly. If the situation gets worse, this palpitation, will start deteriorating, right? And this is where the ECG will be of great help. That's the reason. Because ECG will tell you well in advance, right, that is there any development, anything is happening. Now the thing is, one point of warning. ECG will not give you the level of intensity of hyperkalemia. With ECG, you cannot say that, yes, this is severe hyperkalemia, right? Yes, because in both the cases, potassium is doing the garbad, and that is leading to improper contraction of the muscles. So whether it is a cardiac muscle, to palpitation, whether it is abdominal muscle, that is the digestive muscle, so it will lead to nausea, vomiting. If it is about skeletal muscles, so it will lead to loss of muscle tone, so that is flaccid paralysis. And when it is nerves, so it is paresthesia. Basically, wherever the cells are, those cells are not functioning properly. Reason, you need to go for serum potassium. That when you go for serum potassium, you will come to know that yes, this is what is happening, right? So in case of ECG, ECG is, I'm writing in capital, not the indicator of severity. It is not the indicator of severity, but definitely an indicator of presence. It will tell, right? And there are all the changes, right? What happens to QRS complex, what happens to that P wave, gradually how it disappears, then it becomes a sine wave, all those things, right? But that is when we learn the normal ECG, and then we'll implement this combination. So it is at that point when we'll be learning ECG, I'll ask you the question that, tell me, what would really happen to resting membrane potential and what would happen to sodium pumps? Then, as you'll say, immediately we'll implement that thing into our SA node, AV node, all cardiac muscles, and you'll get the idea. Yes, this is why things are making those changes into that V1 to V6, right? All those electrolytes. Yes, that's what I'm telling. You can't. You just can't know just by watching. That's why history is so important. See, the history is typical. For hyper, history is typical, right? There is crush injury, right? There is crush injury. There is all sorts of accidents, septicemia, major surgery, renal failure, right? You watch the case paper and you get the history that yes, patient is having renal failure since long, right? Chronic renal failure. So that will give you the idea, right? While in case of hypo, it is very typical. Also over here, you ask the patient that taking any medicine in case of hyperkalemia, say if he is taking potassium sparing diuretics, right? He is taking potassium sparing diuretics. Yes, spironolactone he is taking. That means though the urine is going, but potassium is getting spared, potassium is getting stored into the body, right? Typical. One, you ask the question, right, just before some time about this, right? Say, let's talk about it. Say, for example, when you eat something, right, there is glucose, right? There is glucose. Here is the cell, right? Don't look at the proportion. This is GIT and this is cell, right? So there is glucose. The moment glucose is there, boom, insulin comes into picture. Okay, chalo. Now this we need to put this glucose and give it to cells, right? Insulin will act on those receptors, right? Will act on those receptors. Okay, chalo, open, glucose is coming, kha right? So then glucose would really come, right? And then cells would enjoy. This is a normal process. But and meantime, this insulin, he has got wonderful effect on sodium, potassium pump also, right? It would say because the metabolism will be going on, so आप लोग भी ज़रा अच्छे से काम करो, right? So it will stimulate the sodium potassium pump. Sodium potassium pump is extremely sensitive, right? So many factors they will be working on it, but this is one. When things are normal, things are good, all well, right? Things are good, but one fine day, right? For some reason, here is the GIT, right? This is the GIT. Person has consumed, say, glucose, right? He has consumed, but there is no insulin. There is no insulin, right? Now, when there is no insulin, this glucose, right? This is the cell, right? This is the cell. So this is the sodium potassium pump which is going. Now insulin is not there, so no one is stimulating, right? Patient has consumed even the potassium rich food, even kidneys they are not excreting. This is like this glucose is not going. Typical case of type 1 diabetes, type 1 diabetes, in which potassium, when the patient takes this potassium, right, it can rise because now this pump is also not working properly, right? So this is also one of the thing which can really occur. Acha, what you were asking was for this palpitation and the arrhythmia, right? Say when there is hyperkalemia, right? When there is hyperkalemia. Yeah, diabetes mellitus. That's right, diabetes mellitus, right? Because insulin related diabetes mellitus. Type 1, which is right from the birth. Type 2, which is depending upon the lifestyle. So hyperkalemia, right? So when there is hyperkalemia, sodium channels, right? Those sodium channels, they are not working properly, right? So in fact, we can say that sodium channels, they are freezed in action, right? They are freezed in action. So they said कि हमें time ही नहीं मिला, so they are freezed in action. They never work to their efficiency. So when this thing happens, it means there would be difficulty in exciting these cells, right? Exciting cardiac cells, right? So when the cardiac cells, they are not excited, right? When they are not working, so this will be fatal. And this would be fatal. This is what leads to that cardiac arrhythmias. So immediately heart won't stop, but because of this, few cells are working, few are not working, and that thing, it keeps on going and it becomes more and more worse, right? Yeah, bacterial growth in blood. Yes, that's right. That's right. Because as that's the that's the thing, that's a complication of any of the diabetes, right? Because glucose is one of the finest culture media. So it is, as it rises, yes, it can lead to that, right? So this is what really happens in case of hypokalemia and hyperkalemia. In both the cases, clinical symptoms, I wanted to emphasize on that the clinical symptoms, they are quite similar, but the history is important and the lab reports are important. And then it would come in the form of ECG, right? Because your treatment will purely go accordingly, right? So this is a very conceptual part. Okay, if I ask one more question, when it comes to sodium, right, when it comes to sodium, so it is called as, when the sodium level is high, so it is called as hypernatremia. Hypernatremia. And when it goes down, obviously it would be called as the hyponatremia, right? Let's pick up this condition. What would be the effect of hypernatremia on RMP, resting membrane potential? What would be effect of hypernatremia in RMP? Whether it would increase, right? It would go plus or it would go minus. Whether RMP would be raised or RMP would be dropped, right? When there is hypernatremia. Normally, this is the normal levels. The normal levels into the, say, ECF, extracellular fluid, that is in the range of about 135 to 145, right? This is 135 to 145 and should be maintained very strictly, right? Should be maintained very strictly. So this is the thing which, huh, more electropositive, increased, and that's why I wanted to trick you. Haha. The thing is, nothing would happen. अरे इतनी देर से बोल रहे हैं यार कि RMP is depend on only the potassium. Sodium to will come up when the proper voltage will come, and then that boss will come and he'll fire. For resting membrane, he'll say कि अच्छा potassium, you finish the work, right? I am not over there, because the permeability of sodium channels at resting membrane potential is zero, right? At resting membrane potential, sodium would come into picture. See, that's what we are drawing, right? At RMP, at resting membrane potential, it was the sodium. Sodium was the boss, right? He was handling everything, right? Then when it is like from minus 80, when it reached at minus 65, right? कि अच्छा boss, everything is ready, आपका voltage आ गया, तो then our sodium जागा कि हाँ चलो चलो now अपने काम करते हैं, and then they go, right? Yes. So in case of hypernatremia or hyponatremia, they won't have any effect on RMP, right? It won't have any effect on RMP. But yes, its effect would start later on. So that's sodium is the boss and workload is on employees. Actually, so it is like that, right? But no, sodium will say, okay, see, I'm like a front runner, right? I'm like a front runner. So when it comes to attack, it is that sodium will come. Achha. So this is like the point to emphasize, that it won't have any effect on RMP. Right? It has got several other effects. There is a clinical significance, and yes, these are also one of the very wonderful topic, extremely fine topic. But this is just the concept, right? It won't be having any effect on RMP bus, right? So this is for today, and tomorrow we'll be taking our entire, say, discussion from this point to the action potential, right? And then we'll see that how this action potential, it happens in skeletal muscles, how it happens in cardiac muscles, how it happens in smooth muscles, and then there are subtle differences. At this point of time, right, when we'll be discussing action potential, we'll also be picking up some part of histology because it has got some importance. So we'll talk about it, right? That's right. Sodium will affect in depolarization. The entire depolarization business is handled by sodium, right? Yeah, that's what I say. That in clinical, because when we discuss it with clinics now, otherwise it keeps on confusing. Because hyper may be muscle flaccid, hypo may be muscle flaccid. How is it possible, right? And then mara ratta, right? Bus. So no, that's why parallelly we'll keep on taking. And the advantage would be when actually you'll learn the clinics, you'll feel ha yes आ गया समझ आ गया, and you never forget, right? So that's it for today. Thank you so much, and see you tomorrow, same time. Thank you, and see you tomorrow. Thank you, thank you. Even I enjoy, right? Because when you participate so actively, I also enjoy. Thank you, everyone. Bye bye.